I'm Peter Block here in Anaheim, California at the AHA annual meeting. For On the Scene with me is Paul Ritker from the Brigham and Women's Hospital in Boston, my old stamping grounds. Paul, I guess I have to turn to you and say, finally. So for all of those out there that don't know what I mean, go ahead and tell me about this trial and why you finally have reached the point where you've been wanting to go for a long time.
Well, Peter, thank you very much for that kind introduction. It has been over 20 years of pursuing this one idea, which is how important is inflammation in atherosclerosis, and ultimately can we lower inflammation to reduce atherosclerotic events. So the end game of this is the Cantos trial, the canakinumab anti-inflammatory thrombosis outcome study, using a very unusual drug. Canakinumab is an interleukin-1 beta inhibitor. It's a very narrow spectrum drug that blocks one pathway of inflammation. No effect on LDL cholesterol, no effect on HDL cholesterol, no effect on triglycerides or platelet function. It just takes out a little piece of inflammation. And as we showed in the main trial, we had a 15% reduction in heart attacks and strokes, a 17% reduction in MACE+, which has just changed the game. Because remember, that's as big an effect as we get from a PCSK9 inhibitor, but we did this with no impact on LDL at all. We did it purely by lowering interleukin-6 and ultimately lowering high sensitivity CRP, the biomarker that we use for this process.
Okay, so let me interrupt, because the implication of that, Paul, as I see it, is that the biology of LDL lowering and the biology of inflammatory lowering is very different.
That's right. We're learning that exquisitely. So at these meetings here in Anaheim, we've shown that the magnitude of the reduction you get in either IL-6 or CRP, the biologic response to the drug, completely drives the response. So for example, if you were in our responder group, more than a 50% reduction or getting your CRP below 2, we suddenly saw a 30% reduction in cardiovascular mortality, a 31% reduction in all-cause mortality, and about a 26% reduction in vascular events on the responders.
So how many of these people are really responders and how many are not? That's a critical issue.
Well, we define responders as a more than half. So it's the 50% of the group. That means that people in the other half got a response, but it was much less robust clinically. So as a clinician, I might now think, okay, perhaps I give one dose and see how the patient does. And on that basis, I choose to give the drug or not. It's personalized medicine. It's exactly what we've all been looking for to figure out, how do I get the right drug to the right patient at the right time?
Perfect. It's like LDL for cholesterol lowering. Statin for cholesterol lowering. You give a drug, and if it doesn't work, you try something else.
Well, that's exactly right. So I think lower is better, we now know is probably going to be true for inflammation biology as well as for LDL biology. But you know, Peter, there is a twist in this data. So our colleagues in the Fourier study have shown elegantly that the lower you get the LDL, the better off we are for cardiovascular events. But they've not been able to show a reduction in cardiovascular mortality or all-cause mortality. And that might be because you have to treat for a much longer period of time with the lipid hypothesis. It's quite possible. We're seeing these cardiovascular mortality and all-cause mortality reductions within months. That's telling us the biology of inflammation lowering is different, and I think it's pretty exciting.
Okay, so for all the clinicians out there, this sounds pretty sort of up in the air, researchy kind of stuff. What do you see happen clinically with this, Paul?
Well, I think now the sponsor of this trial has a challenge. They're going to have to decide, do we want to seek an atherosclerosis label for the drug? They've announced that they do. The regulatory agencies will now have to say we have an entirely new therapeutic direction. We'll see how that plays out. I think from a patient's perspective and a doctor's perspective, this is good news.
So about as exciting as anything could be for the inflammatory side of heart disease and cardiovascular disease. Thank you, Paul.
It's my pleasure.